get started now. Thank you for tuning in for the last Grand Rounds before March break. It's snowing out there, so we were just talking about skiing, so I'm not sure the snow here is going to do us much good. It's a little dusting, but anyway, some of us will be going skiing for March break and hope you get to enjoy it. So I want to welcome Dr. Keivan Kushan, who's hosting our rounds this morning with the resident team of Joby Wong, PGY2, and Jen Quinn, PGY3. Dr. Kushan is an assistant professor in our department, and he's a staff ophthalmologist at the Toronto Retina Institute and Mount Sinai Hospital. He attended University of Toronto for his medical school and his residency at McMaster, and he subsequently went on to finish a 2-year medical surgical retina fellowship at the University of Florida, Jacksonville. He's very involved in teaching both our medical students and residents, and he's an investigator in multiple clinical trials. He's also quite internet savvy, as he's the creator and host of the Retina Channel podcast, a venue for discussing new publications in retina. So welcome, Dr. Kushan, and our residents. Who's going first today?
Thank you, Dr. White. I think for Joey is going first today, and she's going to talk about a case of CSR masquerading as another entity, and that's going to give us sort of an avenue to talk about white dot syndromes a little bit.
Okay, perfect. Thanks everyone for attending Grand Rounds today. So our presentation is entitled "It's Not CSR," so we're going to try and figure out what it is instead. And thanks to Dr. Kushan, Dr. Bakshi, and Dr. Michelli for their help in preparing this case. So we'll just dive right in. Our initial presentation is this 29-year-old African-Canadian woman who presented 1 week ago via emergency to ophthalmology at another hospital. At that time, they were diagnosed with CSR. However, because they developed a painful red right eye, photophobia, and headaches, they then presented to our emergency department, where we were then consulted to see them. So on history, this patient doesn't have any obvious exposures, no fever, rashes, pets, diarrhea, no UTI, raw meats, and no obvious exposure to TB. This patient was not vaccinated for COVID, either once or previously. Past medical history, just notable for fibromyalgia and a previous ectopic pregnancy, and then some medications, PRN, mostly for the fibromyalgia pain. So we go right into the exam. Her vision, she has 20/50 + 1 in the right eye, 20/20 in the left eye. Pressures were 11 and 18. And then when we look at her eyes under slit lamp, the right eye is injected, whereas the left is white and quiet. Both corneas are clear with no epi defect. In the right eye, we see the AC has 1+ cell. The lens is clear, and then there's 0.5+ vitreous cell. And whereas in the left eye, there's an AC that's deep and quiet with trace vitreous cell. So this patient was actually very photophobic, and so it took a while to get to this point in the exam, but given the presence of cells, we thought dilating her would provide some relief and also let us look at the posterior pole, and the dilated fundus exam then revealed these white round chorioretinal lesions. We didn't see any snowballs, and she appeared to have normal nerves. So as she was dilating, we thought we would get an OCT. And so here's her OCT of the macula. You can see the right eye here and the left eye here. You can see maybe why initially the diagnosis was CSR, given the presence of some submacular fluid here. And here again is the OCT of the macula, just to show you again the presence of the subretinal fluid.
And just a quick interjection, just a reminder, I forgot to remind everybody, please use the chat box for any questions you have during the talk, and we'll try to moderate them at convenient moments. Thanks.
Perfect. So while you think of your questions, we have a question for you. So given all this information you have now, what would the diagnosis be? So we have a bit of alphabet soup. MUDS, like multi-evanescent white dot syndrome. AMPI, VKH, a neoplastic process, or you think it's CSR? So we'll give everyone a minute to answer.
About 10 more seconds. Okay. We'll launch the poll.
All right, so there's a bit of an even split. Everyone got the title slide, so it's not CSR, but it sounds like there's still a reasonable differential here. So let's move on and see what else we can gather from investigations. Okay, so we wanted to discuss first briefly CSR masquerades, especially in the context of having the bilateral macular subretinal fluid. So whenever we see that, it's easy to start thinking, oh, it's CSR first, but remember there's a differential for what CSR could masquerade as. So one would be AMD and pigment epithelial detachments associated with that. As well, an optic pit causing a serous retinal detachment, which could also present bilaterally. Could also be polypoidal choroidal vasculopathy, an inflammatory or infectious process causing exudative RD. And here, this is in the direction we're leaning, given the anterior chamber inflammation. And then finally, not to forget about neoplastic causes, like whether there could be a choroidal tumor causing serous RD.
Joey, can I interject for a second?
Mm-hmm. Yeah.
Just previous slide that you had the differential, like some of these entities overlap now, like the AMD and polypoidal and CSR. They're sometimes over a spectrum of diseases of what we call pachychoroidal disease. And some young person may present as CSR, and later on in life, they may develop into choroidal neovascular membrane and like polyps in a polypoidal manner, or even in a frank AMD. So a lot of diseases are more like a spectrum, and we don't think of them as one single entity as much anymore. But at some point, we'd have to give them a name, just for a side point here.
Perfect. So some nuance in the diagnosis between these entities. So here I'm presenting the fundus autofluorescence for this patient. So if you look at both photographs, you can see there's some areas around the macula in both eyes that are hypofluorescent. And in the left eye, some areas of hyperfluorescence, like dot areas here. It's a bit unusual. And then taking wide field fundus photographs, you can see that these are hypofluorescent placoid type lesions around the macula and nerve. Have a look at both of these. And this was on the data for presentation to us. So then at her next visit, we were able to organize a intravenous fluorescent angiogram. And so I'll just run through that here. So here we have a choroidal flush in the right eye, showing some areas of blocking. And so if we look at the early phase, we can see these areas of early hypofluorescence or blockage. I'm going to run through the slides. Here in the other eye, we can see some early hyperfluorescence now. So in the right eye, we're seeing these areas of late hyperfluorescence and staining present in the other eye as well. So here we arrive at the diagnosis of AMPI, which stands for acute posterior multifocal placoid pigment epitheliopathy. And this long name was initially designated by Gass in 1968 and thought of because it was thought that this was RP inflammation. So we actually don't think that's the case now, and we think instead it's an inflammatory chorioretinopathy at the level of the choriocapillaris, and it is one of the white dot syndromes. So the pathological process is thought to be most likely a primary inflammation of the choriocapillaris with some photoreceptor disruption. So to remind everyone of this entity, it's usually a bilateral process. There's equal distribution between men and women, and the age of onset is typically in the late teens to early 40s. Typical presentation includes painless sudden vision loss, photopsias, and paracentral scotomas. So you can see how this could mimic CSR. Usually there's also some sort of bilateral involvement, plus or minus a headaches or flu-like prodrome. And this patient had presented to us with fairly severe headaches. So the other processes to think about as well when we see this presentation, especially in the context of this IVFA and photographs, is to consider other white dot syndromes. So here we've reviewed the other white dot syndromes and why in this case this is less likely on the differential compared to AMPI. So in particular, there's the other entity, relentless placoid choroiditis. So this is thought to be maybe a extension, or there's some overlap with AMPI. And so if we would see more lesions and they're still present after 6 months, then we could make the diagnosis that this is instead relentless placoid choroiditis. Another entity on the differential is serpiginous chorioretinitis, which would usually show lesions spreading outward in a serpiginous fashion. Usually it's more severe and chronic as well. So typically we should see more lesions that are centered around the nerve and that they're moving outward. So many people also answered maybe this could be MUDES, and this is a reasonable thought, but MUDES is typically unilateral and the lesions are usually smaller. So if you saw the same presentation, but the lesions should be less placoid-like and more like dots, and usually would be in one eye. Also to think about multifocal choroiditis and panuveitis, for which you may see discrete macular lesions and then later CNV, and the same with punctate inner choroidopathy, where also you would usually see discrete macular lesions and less of this placoid type of lesion, and it would be important to monitor for CNV in that case as well. And lastly, birdshot chorioretinopathy. Usually this presentation is more insidious and there's vitritis. Typically the lesions are smaller than an AMPI. And again, we also have to think about CNV later on.
Joey, can I just stop for a second here again? So I saw in the poll a lot of people chose VKH as well, which is a very reasonable diagnosis in this case. VKH also presents multiple lesions like that, multiple spots of subretinal fluid, bilateral, same age group, again, pigmented population. That's a reasonable diagnosis as well. What's different in VKH a lot of times is just the OCT pattern is different. When you see a VKH patient, you do have subretinal fluid, but you all have these cavities and cystic spaces, that is tenting of spaces. And sometimes the fluid is a lot more striking than what you saw here. But VKH in this case is also quite reasonable. In AMPI, you have these kind of nummular changes, as in your case, you have these white-looking, creamy-looking spots in the posterior pole. It's very typical for AMPI. VKH is not like that as much. It can be quite different sizes and different places and more widespread than AMPI. You have this nicely arranged posterior pole creamy spots. But that's a reasonable diagnosis for whoever chose that. And also for VKH, you have other manifestations, obviously neurosensory manifestations, you have dermatological manifestations, you have some more host of systemic things.
The anterior uveitis typical for AMPI as well?
You can, you can have, the eye is hot. So when you have the eye is hot, you can have some cells in the anterior chamber or the vitreous cavity. Same for VKH. So that's not quite reliable. Both of them are kind of uveitic syndromes, but to different degrees and different people can manifest differently.
Perfect. So we'll move on to our next question and to ask whether there should be some additional workup for patients presenting with AMPI. We'll just pull up the poll. And so we can choose from doing some visual fields to monitor disease. You could do a CT head to rule out mass. You could do MRI, MRA of the brain for cerebral vasculitis. We can do an ERG to look for rod cone abnormalities. We'll just try and pick from one of these additional workups.
We'll give another 10 seconds. Okay, stop the poll.
Perfect. Okay, so we're between MRI, MRI brain for cerebral vasculitis and some visual fields. And a few people picked ERG. So we'll go through that. Okay, so for this patient, we did an extensive workup. This included the typical workup for uveitis. So we looked at her CBC. We did some infectious testing, including HIV, toxo, syphilis, as well as TB. And she did a TB skin test with her family doctor, which was negative. We looked for TB sarcoid with ACE and chest X-ray. And we did an inflammatory workup as well with ANA, ANCA, HLA-B27, ESR-CRP. So with this workup in general, she essentially had negative results. We also treated then both eyes with anti-inflammatories and steroids. So she was started on Durezol 3 times a day in both eyes, Nevanac 3 times a day in both eyes, as well as Maxidex ointment at night, Cyclagil to dilate the eyes. And we then ordered an MRI, MRA brain to rule out cerebral vasculitis. And just recall as well in her presentation, she did present with headaches. So just wanted to discuss AMPI a little bit more as an entity. Typically, it is a self-limiting disease with 4 weeks to 6 months time course for recovery. And typically there should be good visual recovery, and steroids could be considered to reduce duration of the symptoms, either topically or systemically. In this review in 2009, the authors reviewed all of the AMPI cases that presented to Mass Ioneer Infirmary for 10 years. And in this, they found that about 50% of the patients were treated with topical or systemic steroids. The final visual acuity was at least 20/25, so very good in eyes which did not involve the fovea. And it was less common in the eyes that had foveal involvement initially. So in this patient, she did have foveal involvement, as you saw with her OCT. So atypical features for AMPI would include unilateral presentation, an older age, or recurrence. And in these cases, it's important to consider other diagnoses as well. And then finally, in reviewing multiple AMPI cases, this 2016 review found that there was cerebral vasculitis affecting patients in 50% of the cases. So it was actually quite a common association. There were also headaches in about 27% of the patients. So this was lending further evidence to why a more urgent MRI and MRA should be done for these patients. So after we treated our patient, we reviewed her again in a week, and we can see that there's less submacular fluid compared to before. And in the left eye, it's getting closer to resolution there. We then took photographs again that same visit, and we can see that perhaps compared to the first time, there's less prominence of the placoid lesions. And then 2 weeks later on the same treatment, you can see there's resolution of the subfoveal fluid. There's still a little bit of fluid here adjacent to the fovea in the right eye. And then 4 weeks later, we have full resolution of this subretinal fluid, and the patient regained her vision. So overall, in our case, we went over CSR masquerades and reviewed other white dot syndromes in our differential when we have this sort of presentation with retinal lesions. And we went over AMPI in a little bit more detail in terms of its investigations and management, in particular, the importance of investigating for CNS vasculitis. So thank you to Dr. Kushan, Dr. Bakshi, and Dr. Michelli for their help with this case.
Thank you, Jovi. That was great. I also want to thank Dr. Bakshi and Dr. Michelli for their help in this case and this presentation. I saw some hand being raised, and I agree with Dr. Burt's comment that she did not get vaccinated just a week before this. Otherwise, there will be another contentious issue about vaccination and autoimmune diseases. So that's quite accurate. Should we address questions now, Sandra, or at the end?
Dr. Lloyd, what'd you like to do?
Well, aside from Dr. Burt's interesting comment about how the presence of a vaccine would have made things even trickier to diagnose this, I don't think there were any other questions. Dr. Bakshi just made a point about this patient having something called bacillary detachments. Maybe you can comment on that.
Yeah, so I actually have a slide with the bacillary RD here that we found. So just on exam, it appeared that she had another pocket of subretinal fluid. So I was chasing it around with the OCT, and then we found this area down here in the right eye near the inferior arcade where there is another pocket of fluid and a bacillary RD. And then Dr. Bakshi had a look and found that this has been reported before in AMPI as well.
Very interesting.
And bacillary detachment being the detachment at the level of the photoreceptors.
Okay, I don't see any other questions just at the moment. Dr. Bakshi is about to scrub in to KEI. So if any other questions to her or the team here, make it snappy. Otherwise, we'll move on to the next talk.
Let's see, there's a couple of questions. Maybe for Dr. Kushan, how would we manage, or Dr. Bakshi together, how would we manage cerebral vasculitis, and why was HLA-B27 done, from Dr. Epstein?
Well, in cerebral vasculitis, obviously, you need the whole neurology or internal medicine team to help you out there. But I think one value of treating these patients with corticosteroids at the beginning versus observing them, which both can be reasonable options, is to prevent or treat some degree of cerebral vasculitis. So if you give steroids when you're suspecting AMP or many of these white dot syndromes for that matter, then you can potentially reduce systemic involvement. So obviously you're following with the neuroimaging, but the corticosteroids is going to be your main way of treating these.
The other question, if you think it's relentless placoid core retinitis, do you consider early immunosuppression? From Dr. Savon-Tayab.
I honestly don't know. Obviously, you need to treat all these with steroids as we chatted, but how aggressive you're going to be if it's relentless placoid core retinitis, you probably definitely have to treat with corticosteroids. Maybe switch them to immunosuppression for the long run, because you can't keep someone on steroids in the long run. So you probably have to be a bit more aggressive in your treatment, both initial steroids and also long-term immunosuppression.
And the other question, that what sort of visual field test do you recommend for these patients?
Probably.
Go ahead, Dr. Bakshi.
Oh, sorry. No, I was just commenting if it was relentless placoid, they definitely 99.9% would end up on immunosuppression and probably immediate biologics as a immediately vision threatening indication.
Thank you. Okay.
Just as maybe Jen is bringing up her slides, what visual field testing do you recommend for these patients?
Well, I don't think any particular visual field protocol is going to be better than the other. They're going to have visual field deficits. So if I were going to choose, I would just do a wide angle like at 30-2, just to see what's missing. Because they're not particularly macular involvement, they're all over. If I were going to choose visual field, but that's not your main way of following these anyway. And a lot of these white dust images, while we're waiting for Jenny's slides, patients' demographics quite important too, right? A lot of them, they happen in younger population, maybe except birdshot, and a lot of them they have a female predisposition. Mind you, AMP is supposed to be equal between males and females, same as mute, but many of them you do have a female predisposition. Some of them even a female myopic person, like you have something like PIC or you have multifocal choroiditis panuveitis. A lot of them are like a young female myope is your sort of poster child for many of these diseases.
All right, are you ready to go ahead, Jen?
Yeah, I'm ready.
Okay.
Can everyone hear me? Okay, so I will start my grand rounds titled An Immunocompromised State, and I'm Jen, I'm one of the PGY3s. Thanks to Dr. Kushan for all his help on this presentation. So, okay, I want to introduce everyone to Mrs. V. Mrs. V is a 46-year-old female, and she has a previous history of a mixed connective tissue disorder. And as a result of her MCTD, she has numerous other health issues. So she has inflammatory arthritis, she has interstitial lung disease, and she also has inflammatory arthritis. Inflammatory myositis was the first one. And as a result of her arthritis, she does ambulate with a walker. And because of her MCTD, she does take multiple medications, including long-term prednisone. So she's been on this for a while. She's on rituximab, and then she's also on monthly IVIG. So I'm introducing you to Mrs. V because she presented to the Emerge with 2 months of fever of unknown origin. And although she had all these other issues that she was dealing with before, she did come in with worsening of her shortness of breath. She was having chronic diarrhea as well and persistent abdominal pain. And then worsening leg pain, and also had developed lower extremity edema. So she was worked up, a lot of blood tests were done for her and imaging was done for her. And what came back showed that she had pancolitis based on her CT of the abdomen, and it turned out to be C. diff pancolitis. She had pancytopenia as well, and also viremia. So she was admitted, and all of these issues were addressed, and treatment was started for them. But while she was admitted, she also mentioned that she was having this blurry vision in the right eye. So at this point, we are consulted. And at this point, what do we know? She's a 46-year-old female, has some sort of autoimmune condition that she's already dealing with. And now she's being admitted with viremia and C. diff colitis and complaining about blurry vision. So she was admitted and treatment was started for the viremia and C. diff colitis, of course. So she was put on Vanco and valganciclovir. And going a little bit more into her ocular history, turns out she never had any eye problems prior to this, no past surgeries. And the blurry vision in the right eye had actually been going on for a couple of months. She's had floaters for a number of years, which have been stable, and she hasn't had any flashes or any other problems in the eyes. So looking at her examination, we can see that her vision is pretty poor, especially in that right eye. There's no RAPT and her pressures are fine. Looking at the anterior segment exam, she had some trace AC inflammation in that right eye and a cataract as well. In the left eye, she also had AC cells, a bit more than in the right, some trace anterior vit cells as well, and then also a PSC cataract in the left eye. So now that we look at the fundus, this is what we see when we're looking at the macular, like optic nerve area. You can see that there are these cotton wool spots that are sort of following the vascular arcades and fairly close to the disc. It's actually more prominent in the left eye. And if we focus a little bit more actually on the left eye and we look in the periphery, we can see that there are these granular lesions supratemporally, and then there's small areas of heme that were interspersed in between. So at this point, let's summarize what we know. We have a 46-year-old female with a history of MCTD on long-term prednisone and rituximab. And now she's admitted for this viremia and C. diff colitis, and this is what her fundus looks like. So I'll bring up the first poll, actually the only poll here. Based on her history and her clinical exam alone, what is your diagnosis? Number 1, does she have HIV retinopathy? 2, maybe it's progressive outer retinal necrosis or acute retinal necrosis. Number 3, CMV retinitis, or number 4, maybe she has toxoplasmosis.
We'll give 10 more seconds. Okay. Well, people are still voting. Okay, we're going to launch the poll or share the results.
Okay, so the diagnosis that most people voted for was CMV retinitis. So everyone in the audience is quite astute. One thing that I didn't mention, I purposely didn't mention, is that the viremia that she had, it turned out that she had CMV in her blood. So we were consulted for her blurry vision in the context of a CMV infection. Go into the next slide. So just based on the history and the fundus photos and the fundus appearance alone, the presumed diagnosis was CMV. So the appropriate treatment was started for her. She was switched over to PO ganciclovir, and then intravitreal ganciclovir injections were started for her. So she received biweekly injections, and there are a number of weeks that she got the injections. So it was a pretty prolonged course. Although the diagnosis was made clinically, there was an AC-TAP that was performed, and it did come back positive for CMV. So as we just follow her along as she receives the treatment, you can see 1 month later, there are those areas supratemporally, those fundus changes that look to be pretty inactive at this point. The cotton wool spots have improved in both eyes, and there's still some areas of hemorrhages in the left eye, but they were improving. And to note, she was diagnosed with CMV retinitis in the left eye, but there were concerns for early CMV retinitis in the right eye, just because there are these fundus changes inferiorly in that eye. And although she didn't initially present with a lot of AC reaction, it was thought that because she was on the prednisone, this may have had quelled some of the inflammation that would have been present otherwise. And if you look at the FAF, this again is 1 month treatment. There's some areas of hyper and hypofluorescence, autofluorescence that correlate with those fundus changes. 2 months later, things are still looking pretty stable. And then if you look at the OCT, the IVFA in the right eye, it looks pretty quiet. There's no areas of obvious leakage. In the left eye, same sort of story. There are those changes supratemporally, some blockages and staining, and maybe a bit of leakage at the edge of some of the lesions, but in general, it looks pretty quiet and there's no obvious or diffuse leakage. And 3.5 months later, everything's still looking pretty stable. So she did pretty well. A couple months later, she did have a little bit of a recurrence with some more hemorrhages. So she was restarted on her ganciclovir and the intravitreal ganciclovir injections as well. So let's shift gears into talking about CMV retinitis itself. So there's one of some
Jenny,
of those
can I interrupt you for a second? So the treatment that this lady had, I think you mentioned briefly, the intravitreal part is quite heavy. It's twice weekly injections, so it's quite a bit of a burden on this patient when we're treating her for a few rounds. So it's quite tough, but no, she took it really well. And that's not sort of standard. So a lot of times people say you can just do systemic treatment with ganciclovir. and that could be fine. But if you give them intravitreal ones, they do better. And foscarnet is another thing you can use intravitreally or systemically, and that you need special permission for that in Canada. But she did quite well with ganciclovir injections intravitreally plus systemically. And one other thing I want to add about treating CMV retinitis, these patients used to be more HIV positive patients many years ago. That was your first person to get CMV retinitis. But these days, whoever gets CMV retinitis usually is an immunosuppressed patient like this one. We don't have as many HIV positive patients who develop this as much, thankfully. The treatment is not urgent. It's an indolent disease, it's slow growing, and this develops over weeks or months. So you do have a window of opportunity to do your investigation, do your AC tap before anything disastrous happens. Versus in a disease like acute retinal necrosis, you're going to talk about, that's an urgent entity. You got to treat that right away or they're going to get retinal detachment. This one, retinal detachment is not much of an issue. Obviously, you have retinal necrosis that slowly is going to be progressing, but you have a bit of window of opportunity to treat CMV retinitis. Thanks.
Thanks, Dr. Gushin. So here's one of those classic photos of CMV retinitis. And then the question of how it gets into the eye, usually through hematogenous spread. So it can invade the vascular endothelium and then spread to the retinal cells. And it is generally thought of as an opportunistic infection. So typically affects people who are immunocompromised, and classically you associate the CMV retinitis with patients with HIV, whether they're not diagnosed and have low CD4 counts, or they're not compliant with their heart therapy. But you can also see it in other patients who are immunocompromised that don't have HIV, for example, Mrs. V. So patients who, for example, are on long-term corticosteroids or some sort of immunosuppressive agent, or for example, people who have cancer and are on chemotherapy. Rarely it has been associated with patients who are immunocompromised, but this is very exceedingly rare. And so generally these patients are immunocompromised. So how do patients present when they have CMV retinitis? Pretty non-specific symptoms like blurred vision and floaters, which can be caused by a number of things. Some patients may complain about photopsias or scotomas. So again, in general, it's pretty non-specific. And then if you examine these patients, what are you looking for? They may have some anterior uveitis. And I know we're talking about CMV retinitis here, but just important to look at the whole clinical exam. And with these patients who are generally immunocompromised, there isn't much vitritis. Typically, that's like the classic thing that you think about, but there can be a variable amount of vitreous age/cells. And then there are 3 classic CMV retinitis patterns. So I'll give some pictures of each of these. Number 1 is the fulminant or hemorrhagic type. And you can see these areas of necrosis that are interspersed with these many areas of hemorrhage. And typically this follows a perivascular pattern. There's the granular type, which is what Mrs. V was diagnosed with. And so central areas of necrosis that are surrounded by these granular lesions. And typically they start out in the periphery and progress slowly, as Dr. Gushin had already mentioned as well. And then lastly, there's the perivascular frosted branch angeitis pattern, where you have these perivascular exudates, and this is the least common type. Also, when looking at CMV retinitis, you can describe the area of the retina that is affected by it based on their zones. So zone 1, 2, and 3, zone 1 being the most posterior, and then zone 3, you're going out into the periphery. So there's a number of things on the differential diagnosis when you're thinking about CMV retinitis. One of the high ones on the list is HIV retinopathy. Again, classically it's associated with immunocompromise associated with HIV, but there's other infectious entities that are on the list, and also non-infectious entities like lymphoma. But the diagnosis of CMV retinitis is largely based on the clinical picture. So a thorough history for the patient. Often, again, these patients are immunocompromised, or there's some reason that they're developing this opportunistic infection. And then, of course, doing the physical exam, because there are these characteristic lesions and characteristic fundus appearance that goes along with CMV retinitis. Although sometimes there can be maybe a bit of ambiguity if you have these infections or retinitis caused by viruses in the herpes family. Doing an AC or a vitreostat might be helpful in these cases, or just to confirm the diagnosis, because you can get the PCR from the ocular fluids. In terms of blood serology for CMV, may not be as helpful, like a lot of people have been exposed to CMV in the past, but you can get like CMV IgG versus IgM. And having a negative result on blood serology may not be that helpful in immunocompromised patients. Maybe they might not have a good enough immune system to mount an appropriate response. And in terms of treatment, mainstay are systemic antivirals. So for example, ganciclovir or valganciclovir. It's typically done with a high dose induction therapy for a couple of weeks, like 2 or 3 weeks, and then it's followed by a more long-term maintenance therapy. And then you can also add intravitreal antivirals along with it, which can help with the resolution of the CMV retinitis. So for example, with Mrs. V, we used ganciclovir. One thing that should also be kept in mind is that you should treat the underlying immune condition if possible. So for example, for HIV patients, starting heart therapy or making sure they're compliant with it to ensure that there is improvement of their CD4 counts. Sometimes treatment of the underlying immune condition isn't always possible. For example, if a patient needs to get chemotherapy for their cancer, that's something that just needs to be done. So it's all sort of a balancing act. One thing that should be remembered when you're treating the underlying immune condition is that as immune reconstitution occurs, sometimes you can have additional complications related to that, or just simply related to the CMV retinitis in general. So there's the issue of immune recovery uveitis, because as the immune system improves, you can get more of an inflammatory response to the CMV. So you can get the onset of or worsening of anterior uveitis, intermediate uveitis. You can also get ERM formation in CMV retinitis, possibly you can get CME or NV. Other things that may be possible in CMV retinitis as a complication are retinal detachments, because you can have atrophic areas of the retina or thinned areas of the retina that are more prone to developing retinal breaks. And as a result, you can subsequently develop retinal detachments.
Just one thing, Jenny, I want to add about this retinal detachment. We had a good question from the audience that is barrier laser indicated in these patients to kind of limit potential retinal detachment. It's not as commonly advocated for CMV retinitis because RD is not as common, even though it obviously does happen as in this picture, but it's not a major fear. It is a major fear in acute retinal necrosis in RN. RD is quite common in that disease. And even for that, we don't routinely do barrier laser because some people say that can cause detachment itself. But detachment is not a major sort of complication in CMV retinitis, although it's obviously possible.
One other complication, of course, is just a recurrence of the CMV retinitis, which Mrs. B did have. And if that does happen, you reinstitute the systemic treatment and, if warranted, intravitreal ganciclovir antiviral. So we talked a little bit about CMV retinitis, and now shift gears to touching upon non-CMV necrotizing herpetic retinitis. And specifically, we're talking about two clinical syndromes. So progressive outer retinal necrosis, or PORN, which is multifocal necrotizing retinitis in immunocompromised patients, and then also acute retinal necrosis. So it's also a necrotizing retinitis, but this is most commonly seen in immunocompetent patients and often starts more in the periphery. And when we're thinking about these two entities, usually what comes to mind are infections caused by VZV and HSV. So shifting our attention to the first one, progressive outer retinal necrosis. How does this one present? Well, again, it's pretty non-specific in terms of the symptoms that the patients may come to you with. Blurring, floaters, maybe some field constriction. And then when examining the fundus, though, there are some features to look out for. So classically, you have these areas of retinal whitening or opacification, which represents the necrosis of the outer layers. And oftentimes this can be pretty posterior as well in these immunocompromised patients. And again, because these patients are pretty immunocompromised, usually there's minimal to no vitritis in these patients. You can have a vasculitic picture that occurs as well. You can have some vascular sheathing. You can also have some optic nerve changes like edema or hyperemia. And RDs can be a complication of this entity as well. In terms of ancillary testing, the IVFA the appearance may be variable. So you can have like some window defects or some staining in areas of necrosis, whether they're active or inactive. You can have leakage from the vasculitis that appears. And on OCT, you can have disruption of the outer layers of the retina that are corresponding to the areas of necrosis. And you can have inner layer hyperreflectivity. In this photo here, you can also see some cystic changes and some foveal thickening. And then FAF, you can have hypoautofluorescent areas corresponding to the active or inactive areas. So we talked a little bit about this presentation. And if we shift gears and talk about the presentation of acute retinal necrosis, we can sort of compare and contrast how they present. So again, the presentation, like with CMV retinitis and progressive outer retinal necrosis, it's pretty non-specific. So blurring, pain, redness, photophobia, maybe some flashes or floaters. A lot of patients who have uveitis from different causes can present this way. So it doesn't really help you in terms of narrowing down the diagnosis. But if we look at the fundus and we talk about how it presents clinically on exam, it goes through different phases. So first there's the acute herpetic phase, which is representative of the virus particles that are invading the retina and the vitreous, inciting this really intense inflammatory response, because as we know, these patients are often immunocompetent. So on the anterior segment, you can see things like episcleritis or scleritis or anterior uveitis. And because these patients, in contrast to the patients with Bourne, have good immune system, there's often this intense vitritis or vitreous inflammation that's present. And then classically, there is this occlusive vasculitis where you have infection of or inflammation of the retinal arterioles. And then this can cause vaso-occlusion and then necrosis of the downstream dependent retinal areas. And similar changes can occur in the choroidal vasculature as well. And then you get the classic presentation of acute retinal necrosis, areas of whitening and opacification. Often they can start in the periphery and then slowly they can, or pretty quickly, they can coalesce to form very confluent areas. So the American Uveitis Society actually put out some helpful diagnostic criteria. And if you look at these, a lot of these are based on actually what the fundus looks like and the characteristic lesions that will appear in acute retinal necrosis. So once we move on from the acute herpetic phase, we can go into the late cicatricial phase where you have complications related to the acute retinal necrosis and some of its sequelae. So because you get the retinal necrosis and the thinning of the retina, you're very prone to developing retinal tears or breaks and subsequent detachments. You also get other complications like PVR or sort of fibrotic reactions that occur. So we talked about the presentation of both of these entities. And now talking about both of their diagnoses and treatments, you'll see a lot of similarities with CMV retinitis as well.
Jen, sorry, can I stop you for a second? Would you go back to the slide that you had one of the fundus photographs with multiple yellow spots in the periphery? It's useless. Yeah, this one. So this, if you see a patient and you're thinking is ARN and you're at this stage, you probably lost the game already. So ARN, as I said before, really progresses rapidly. And it's a young person, really healthy looking. It's your typical uveitis patient. So, and it can really, from one single spot in the periphery that you have necrosis in the retina, can spread very quickly and cause detachment right away. So that's why you have to dilate every uveitis patient, even though it looks like a young, healthy female with anterior uveitis. You know, you got to dilate, you got to look at the vitreous cavity There may not be a lot of vitreous cells, but even if it's a little bit of vitreous cells, you should look at the retina, make sure you don't have these foci of inflammation, because then it could be RN. Your typical patient, he is a healthy patient, he's a healthy young person, and all of a sudden, similar to the way that HSV or VZV can affect the cornea, these people they get the same virus, it affects the retina, and it can be quite severe. Thank you.
So, so just going on to the diagnosis and treatment. So diagnosis largely clinical, AC or vitreous taps can be helpful in these cases. And of course, it's always important to inquire about the immune status of the patient or take a very thorough history. And treatment is pretty similar for both of them. You can give intravitreal antivirals, and importantly, you have to give systemic antiviral therapies. Again, you start with that induction therapy and then have more long-term suppressive therapy for them as well. There's a question of in immunocompetent patients, some people may give some systemic corticosteroids. Of course, this is after antivirals have been instituted, maybe about 24 or 48 hours later, to sort of help with the intense inflammatory response. Then there's a question of maybe an ARN. I don't know if it's done pretty frequently, probably not, but the question of prophylactic laser, because about 50 to 75% of ARN patients will develop RDs. So going back to the case and just to conclude everything, the patient ended up getting cataract surgery for her PSC cataracts, and she was quite stable in terms of the CMV retinitis. About 20 months later, so after the initial presentation of her CMV retinitis, she came back complaining about blurry vision in the left eye. You can see here, vision in the left eye is poor, 20/70. Turns out she had CME in that eye, and so was started on topical therapy, Durezol, Nevenac, and also Combigan, because she's a steroid responder. So it's not really clear why she developed the CME. Maybe it's like post-cataract CME. Could be CME related to CMV retinitis, but she was pretty quiet, and it's a pretty long time since the onset of her CMV retinitis, so probably unlikely. The topicals aren't working too well, so the next step for her is probably some analog injections. So just to summarize everything, it's really important to have a thorough assessment of all your patients, and especially immunocompromised patients who may present with these fundus findings and these opportunistic infections. And if you do identify something like CMV retinitis, it's important to closely monitor these patients, both in the short term to make sure that the CMV retinitis is improving, but also in the long term to look for any complications like CME or like maybe retinal detachments, which again are not as common as compared to patients who present with ARN. And also it's important, just because since a lot of these CMV retinitis patients are immunocompromised, we need to reinstitute systemic therapy, and often this is done in conjunction with other practitioners in a multidisciplinary team who are taking care of some sort of autoimmune condition or their immunocompromised state. So that's the end of my presentation. Just want to thank everyone for listening.
Thank you, Jenny. It's great.
Great presentation, Jen. Few questions just that were touched on in the chat box that we may or may not have covered entirely. So there are choices of antivirals. Someone mentioned, would you prefer Balgan, Cyclovir? This is from Dr. Kozalewski. How do you, there's some choices. How do you triage the choices? Why choose one over the other?
Yeah, that's a good question. So for CMV retinitis, Ganciclovir is generally your drug of choice. And Ganciclovir can be IV or Valganciclovir is the oral version. When it comes to ARN or porn, the choice is actually Acyclovir. So Acyclovir is drug of choice. You have to do an induction IV treatment or very large dose Acyclovir. So that's a critical difference. And intravitreal injection is Ganciclovir for both, or Foscarnet, but systemically they're different, and that's quite critical because for acute retinal necrosis, for some reason, Ganciclovir systemic doesn't work as well as Acyclovir does.
And then in your CMV retinitis case, one of the eyes had prominent cotton wool spots. So someone is asking, that's not so typical of the pizza pie appearance that we associate with CMV. Is that a typical appearance?
That's a good observation. So that's when she came in initially, when she had other things going on with her. So that, and she had it in both eyes. So we think it could be either because of hypertension episodes, like she had hypertension retinopathy, or it was more like a Percher-like presentation that she had this systemic active viremia in an immunocompromised patient, and then she developed this Percher-like presentation in both eyes. But those cotton spots, appearance around posterior pole, is more like Percher disease than CMV retinitis, and that was transient, went away after she started becoming more stable.
Safwan is asking about the duration of systemic antiviral treatment, I guess both for CMV and then for ARN and PORN.
Yeah, so for CMV retinitis, for this patient, for example, she was on systemic antivirals for months, for at least 6 months. And at the same time, when we look at the eye, as we examine the eye and report back to the rheumatologist, and they also do a systemic analysis of viral load in their blood. So when she was free of any CMV in her blood, and we kind of told them there's nothing in the eye, they stopped the acyclovir systemically, but that took months, at least 6 months. For ARN, it's a funny thing. So ARN, it's a more like a local disease, more or less, right? You don't have HSV or VZV in the rest of your body. Generally, it's a healthy patient. So you do treat systemically, but many times you still have inflammation in the eye or cells floating in the eye months or years after. You're probably going to keep them on systemic acyclovir for a long time. I have a young patient who was a teenager when I met her, and she got ARN from HSV type 2, and that was like 5 years ago. She's still on systemic antivirals that I prescribe, and also low dose Lotemax, and whenever I try to wean her off, she gets more cells in the vitreous cavity, although the retinitis and all that's stable, but she has cells in the vitreous cavity and sometimes in the anterior chamber. So for ARN and PORN, it can be a long, long time being on systemic antivirals.
And then Tom Wright asks, what is the value of electrophysiology in these patients? Does it serve any role?
Well, for white dot syndromes, obviously, we do have a major value, like a lot of patients with Birch retinopathy, they're followed by ERG. For these viral retinitis diseases, it's less of a role for physiology measurement, because it's more like a huge uveitis syndrome. The eye is hot, and you really want to suppress the inflammation with steroids or antivirals. So I'll see less of a value for that, as in my experience. Maybe others who could have other experiences. But for white dot syndromes, there's definitely a role for ERG measurements.
And you kind of touched upon it when you're saying that some of the patients require chronic maintenance therapy. What do you do if a patient who has had CMV retinitis manages to get it again? Is there any difference in the treatment approach?
No, we get the ball rolling again. So like this lady, we had a few months after initial, we thought she's inactive, and then we figured now she's rebleeding in the retina again. And we kind of started her on injections in the eye, and also elevated her systemic dose. Probably the second time you're not as surprised, because you have a diagnosis and you know what you're treating.
All right, I think I've got through all the questions in the chat box. That was a fabulous rounds. Thank you, all of you, for presentations and discussion. And have a good March break, everybody.
Thank you very much. Have a good day, everyone.